Yeah, it's very interesting. If you look at, I can speak to Oregon's budget, not Washington's budget, but if you include early childhood investments, 60% of the budget is in education. 30% is in human resources and public safety. And I would argue that in education, I'm going to get to your question, education, if done well, is really an investment in the future. It's an investment in productivity, it's an investment in success, it's an investment in the workforce. Spending on a lot of medical problems, certainly public safety problems, is really an expenditure. And a lot of that we spend in that 30% of the budget because we didn't do the education part right. I mean, there's a relationship between education and ability to get a good job and that and health, et cetera. But we act in our country as though kids don't exist until they get to kindergarten. And we know there's a set of very well recognized social and medical risk factors that occur in the home and in the community. Mental health and chemical dependency issues, living below the federal poverty level, a whole host of issues which, if unaddressed, those kids have an almost linear correlation between school failure, school dropout, social dependency, and involvement in the criminal justice system. But as a society, we don't invest on the front end. And I think when I talked about creating a health community, it's basically trying to recognize that if you're concerned about public safety, if you're concerned about graduation rates, if you're concerned about getting people off public assistance and into the workforce, you have to have that kind of community investment and involvement in those big determinants of health. It's not the responsibility of the formal medical system, and there's no way the formal medical system can get ahead of that curve unless we begin to make those kinds of investments. And I do think, again, I'm sorry to beat the dead horse, that's only going to happen if we find some communities that are actually going to try to do that and get the flexibility and put the partnerships together. We're working on trying to create a county-wide partnership in Multnomah County to address those very issues. We've got the faith community involved, we've got the business leadership involved, we've got NGOs involved, we've got the county government involved, and it really is trying to identify, it's a minority of the population that are driving most of the cost, to identify those and intervene in an appropriate way to change their trajectory. So that's a very, very good question, and if we view this just as expecting the formal medical system to solve these problems, I think we're doomed to failure.
Thank you, Governor. In countries around the world that emphasize primary care, it would appear that they seem to do a better job at offering care, the quality of care, and the cost of care tends to be lower. In your new model of care, your new delivery system model of care, you seem to emphasize a large primary care group practice, which seems to emphasize primary care. If we contrast that with what's going on in medical schools, where the proportion of physicians coming out who are in primary care seems to be dropping relative to physicians coming out in specialty care, how do we reconcile that with the new model of care, and how do we change that dynamic to get an adequate amount of primary care physicians? Is it just about payment reform, or is there something more?
I think there's two answers to that. Long term, I think it does have to do with payment reform. Obviously, a lot of young people are coming out of med school now with these enormous, staggering debt burdens, and that does clearly have an impact in what they choose to go into. You can certainly pay off your debt burden quicker in certain specialties or subspecialties than you can in primary care. And so I think part of it has to do with medical education policy and payment reform. But even if we turn that around today, it's like 15 years before you really increase the number of primary care physicians. So I think the other thing we need to do, and this is I think a little harder for primary care docs, is I really do think that the primary care physicians, who are the most expensive to treat and valuable resource in the formal medical system, need to really practice to the top of their licenses. And they really need to be doing things that nobody else can do, dealing with these areas of complexity and high ambiguity, and have a much greater use of ancillary health providers, nurse practitioners, and PAs still operating within the context of an organized system, which can, I think, really extend the primary care reach a lot more. I think that has to happen even as we try to change the incentives to drive more people into primary care medicine.
Governor, we have time for 2 more questions.
Okay.
Just briefly, actually, with regard to that comment, I am a primary care physician, and the one fault that I find with that model, and I think it's already being proven out, is, first of all, physicians really aren't paid for time to the extent that you want to address some of these more complicated or ambiguous issues. Secondly, if we take kind of the bread and butter stuff and send those away to the nurse practitioners, emotionally and psychologically, it's very difficult to spend your day with these oftentimes emotional and very difficult issues, and I think you're actually going to decrease the number of people that you get into primary care. So that's just my own personal opinion. I did want to comment on that same slide. You had commented about community health workers, and I think that's something that should be explored a lot more. I think Paul Farmer set a great example in his demonstration in Haiti, showing that it was both health effective and cost effective is something that should be expanded and really pursued with vigor.
Thank you. The cleanup hitter has arrived.
I didn't hear you say anything about this, and I was just wondering, in a society that seems to be very eager to sue, what does the apparent need for physicians to have malpractice insurance play in healthcare reform in the current system?
I think it's very, very important, and I think in order to make something meaningful happen, we have to reframe this debate from a sort of a clash between doctors and trial lawyers to a recognition that there are two legitimate values that we're trying to balance here. One is access to justice, which is very, very important in our nation and in our country. And the other one is the fact that we can't spend the entire public budget on medical care, and there's got to be some way you can actually say no without getting sued. And it ought to be based on clinical grounds and good objective evidence. Actually, I'm brokering a discussion as we speak between some of the leadership of the Oregon medical community and the Oregon Trial Lawyers Association, trying to figure out what that looks like, because I don't think you can actually solve this problem in an era of fiscal limits without having some changes in the medical liability laws, and I don't believe that necessarily means you're going to violate people's access to justice in a legitimate way. Well, listen, thank you very much for having me out here. Take care.